If I could just have the rest of the faculty just come up and we'll take any questions. Namir.
I have a question. I'll wait for the faculty to come, but I have two technical questions. If maybe really it's about single port sleeve. We spend half of the morning, a great morning by the way, Marina.
Thank you.
Very interesting, very to the point, very practical. But you know, we spend half of the morning talking about safety of sleeve and how to avoid leaks and how somebody said that, you know, we need to, I think it was Craig Jossar, who said, well, we needed to have an operation that will lead to very fewer complications. And we all know that we've spent a lot of time looking at leaks. I don't believe that single port sleeve, you know, enhances safety of the operation. You are putting I mean, with all respect, I value the prowess, and I've done single port, I do single port. But like you said, it's a complicated operation. It's not an easy operation. And I don't think single port sleeve or bypass, but I don't think anybody has done a bypass single port to my knowledge. But sleeve, single port is not safe, not at this point, and your data doesn't show any benefit except for fewer scars. And so why compromise good visibility? Michelle just said, I add another trocar if I'm too low. That's what I do. That's what I write. That's what I put in my book. So I don't understand that. And I know that, you know, single port, everybody's talking about it. We come to SAGES, but we're talking less about it, less, and certainly less notes. So I just want to get your gut feeling. Why do you pursue it?
Well, it's a good question. I pursue it for a lot of different reasons. First of all, I don't think it increases the risk for the patient. I have not seen any evidence. Obviously, we have only small series out there. We've just submitted a large series, a multi-center large series of over 100 patients to the American College. It should be presented in the fall, which shows absolutely no increase in morbidity and mortality. So I do not think that there is an increased risk by doing single port. Secondly, I do not think that you actually have compromised visualization. And I think you shouldn't accept compromised visualization. So I think if you're not seeing it right, absolutely, put another port. Well, I think of all the single port procedures, you're asking about ergonomics? Well, of all single port procedures that I've performed, the one that provides you the most functional ergonomics is actually sleeve gastrectomy. I think it actually provides you a very simple ergonomics, and I'd be happy to demonstrate that for you at a live case if you'd like to see it. But I think we've organized the operation in a way that is simplified and reproducible. So I really don't share those feelings about you. You can certainly argue what are the merits of single port, and I'm happy to discuss that. But whether or not we're actually compromising visualization and we're compromising the safety of the operation, I don't think so. I think our goal has been to actually reproduce exactly the operation that I would do with a standard conventional laparoscopic approach. So I would not take a risk on a patient because I'm looking at it from a very compromised approach. Same thing with the Bennett, same thing with the lab Coley. Any other procedure they would do that way, I think it's important that you maintain the basic principles of that operation, and we don't change that. Now, with regards to benefits, and that's arguable and valid point. I think single point is not going to be an application for all operations. I don't think they're going to have multiple applications, but I think there are some areas that you may find that it has benefits. There's data now from Texas, where we are right now in Houston, they submitted to the Western Surgical Society looking at colectomies, which showed improved length of stay, improved pain syndrome post-op. We have looked at data from on gastric banding. When we looked at large series, we see a minor benefit. I don't think it's necessarily a major dramatic revolution in minimally invasive surgery. I think it's a mild evolution. It's gotten us all to think about what we do to our patients, and we're going minimally invasive. Mini-lap has been rediscovered. So I think there is merit to the discussion.
Michelle and then Raul.
Yes, I don't see patients coming and asking for it. So that means it's the surgeon who's pushing this for the patient. I would rather see the difference that the patients are really asking for this because they think that there's a cosmetic benefit and other types of advantages, but I don't see this right now. And then the other thing is, if you select properly the patients who will have a large panniculus, you'll have, and I prefer this one, the single incision panniculectomy. In that one, you know, if we have trocars that are at the level of the umbilicus, multiple ones, they will be moved down and there will be nothing really visible after that. So I think, you know, you get a better operation. You saw all the different maneuvers. We need to do a lot of sewing to prevent that 1 or 2% of leaks and get better visualization to get adequate sleeve in this upper part. And I think that it's difficult to do this from a single port umbilicus technique.
I want first to second Amir and Michelle's talk. I also, as usual, strongly disagree with Julio. I mean, he's been for 15 minutes on the stage talking to us, and he wasn't able to produce a table with a prospective randomized trial that can convince you that single port has any use at all. And then in the microphone they say, well, because Texas in colectomy and New York did it with cholecystectomy. There is nothing in the literature that shows that single port has any benefit at all. It's anecdotal. These are collected series sometimes where they shake them all and put them in, they do a blended thing and they say, oh yes, less pain. You cannot measure pain. But the most important part, coming back to Namir's point, is not only about the safety, is that we spend the whole morning trying to discuss how to do the sleeve, how important is the volume, how important is not to twist the sleeve, how important is to avoid a stricture, to keep the angles, etc., etc. Surgeons that have done 1,000 of those, they tell you, I add another trocar to make sure I keep an angle. So what we are doing, or what we are not doing it because, you know what, Julio, you and a couple of other guys are the ones who are standing here talking about that. The great majority doesn't believe and doesn't do it. Can we have a show of hands? How many of you guys are doing single incision sleeve? Thank you. So, 1 second, we have here 300 people, 200 people, so it's not a problem for us. The problem is going to be for you and your patients because it is not about reproducing the technique, it's the results. And the results in bariatric surgery are not measured at 1 year or 2. Every operation works for the first 2 years. It's going to be measured at 5 years. And I would like you, in 5 years from now on, to be here and show me your weight in your patients after a single incision sleeve. That's what I think.
And just for everyone, although I know you all have gotten the picture, Raul is not a fan, not been a fan or proponent of single incision surgery, and so he does have very strong opinions about it. I'm going to give you the chance to rebut. Absolutely, Julio. I just, you know, some of it for us, you know, Michelle, you said that patients don't come and ask for it. Well, we do see in New York people asking for it, but I'll tell the patients I only do about 20-30% of single incision, and I do it in select patients that I know it's going to be a lot easier. And many of you know that I am a little bit foul-mouthed. I've behaved myself today, but usually in the OR, when I'm doing a single incision, it just goes up exponentially, and it's because of all the hand jamming and the difficulty and the loading on my wrists. And it's a much harder procedure. I don't do single incision sleeve yet. I'm trying to get my sleeve numbers back up to where they should be now that there's insurance approvals. And I just, from a medical liability standpoint, I want to have that, 500,000 cases behind me before I do it. Julio, and what do you think about your liability for something like that?
It's a good question. I don't think it's necessarily a change in paradigm. And we don't necessarily tell patients you're going to get a single incision operation, and that's the end of the story. Certainly, we reserve the opportunity to introduce more pores and to be flexible about it. The idea is to be most minimally invasive with our patients. Now, you certainly can disagree with the approach, and you can choose to do whatever you want with your patients. What I'm saying to you is that we are studying an approach here. No one is saying that we have the final answers to this approach. And there's many investigators who are studying this approach in other areas, not just in sleeves, but in other areas. There's been suggestions here, for instance, about doing other experimental procedures, such as, for instance, the use of bypass of their sleeves, for instance, or revising the sleeves with other techniques. These are all very anecdotal experience with a lot of scientific data. You presented a table up here of the scientific evidence with sleeves. And there wasn't one study, there was a level 1A study on your chart. So this is not about gospel. Well, if you
Okay,
let's
okay,
finish.
guys.
Let me just finish.
Yeah.
We
You
can,
know,
we
No,
can, we can.
You can duke it out down there. We're going to take a couple of questions out. Julie, are you essentially finished?
Well, I just want to say that this is not gospel. This is about science. What we're trying to do is study this methodically.
Science, are you doing prospective randomized IRB?
Yes, we are. We, in fact, are presenting a study tomorrow, a randomized prospective
And
trial.
Raul will be there
Okay.
at the
and
microphone.
I'm happy if you're there. We have other studies going on. We're not the only one doing studies. And certainly, this is about science. No one is saying that this is the end-all to laparoscopy. But what I'm saying to you is that this is not about gospel. Opinion is not what leads here. It's
said
about
gospel.
science.
And even when you have randomized study with results, it doesn't even translate necessarily for people to adopt the technique. When we had randomized study, and now there's meta-analysis of randomized study of needlescopic cholecystectomy versus lap chole, it showed better cosmetic result, less pain, and still people are not doing it.
Well,
And,
yeah, I
and
agree.
just
I
for
mean,
everyone,
I think
Michelle's
I
study
think
was from
just-
1996 and
I
97.
think that's a very important point, and it points to the hypocrisy that exists in the surgical community. If you look at how many studies have been done looking at the advantages of laparoscopic colon resection over open, and yet the penetration in the market is 20%.
But, you know, I'll just, because I've looked at this myself, you know, we were in 1990s with worse cameras, right, than we have now. We have such amazing optics right now. And then now we've taken our upper abdominal incisions for these single incision procedures and put it the umbilicus, and your optics are less because you're further away, or if you use a long scope, things get more grainy. My reason I say that is I think for some people, perhaps the newer thing to do, at the time, needlescopic was not embraced because you really couldn't see as well. Well, now, I mean, I think this might be a chance, you know, for the needlescopic to come back because it's there. And if you, and the only reason I do silts, because it does kill a bilateral carpal tunnel, is for my surgical machismo. If you want to be macho about it, to do the silts, just so you can do it, that's something, but you have to do it safely. And you want to do the same operation that you did with multi-trocars with your single incision. I'm going to go to the back mic.
Yeah, I have a question about the technique of while resecting for the sleeve. Actually, there's a lot of variability among experts in the literature about resecting with reinforcement, without reinforcement, with suturing at the angles. All kinds of things have been mentioned. I think in my experience of 300 plus sleeves, I think the main reason why it leaks is there is a narrowing in the lower portion and the pressure builds up. It is not the technique per se of suturing, because everything has a downside to it. If you suture through the whole staple line, you will run into bleeding while putting sutures, and there will be a submucosal hematoma, and the patient has an obstruction postoperatively, and the patient will have to stay in the hospital for 6-7 days. So I've seen that patient is not able to even swallow their saliva postoperatively if you suture. But selective suturing, I agree, but the whole staple line suturing has a downside to it.
Let me respond to that. Again, you know, if we want to be scientific about it, we submitted an abstract to the meeting in IFSO, and you need, as Raul pointed out, you need 10,000 sleeves to make the point about reinforcement, no reinforcement, what happens to this whole issue. Everything under that is not enough. Well, we got the 10,000 sleeves. You'll be happy to know that in this analysis, the leak rate is 3.2% when no reinforcement is used. When suture is used, you decrease your leak rate to 2%, suturing the whole staple line. When you use absorbable, you go down to 1%. So here you have
Is that absorbable buttress or suture?
absorbable.
Absorbable,
But there's questions
absorbable what?
Absorbable buttress, sorry.
Okay.
But you're looking at meta-analysis of multiple surgeons using different techniques,
Yeah,
correct?
this is still not a randomized study, but you know, to put a randomized study on 10,000 patients, I invite everybody in this room to participate.
I agree, actually. I prefer absorbable reinforcements on the staple line, and I do selective figure of 8 sutures. I don't think there's a need for the complete suturing of the staple line.
Front mic, you've been very patient.
Sunil Popat, India. Excellent presentations, enjoyed everything. Just have a question for every presenter regarding the size of the cartridge, the staple size. Are they all using first 2 or 3 green and followed by blue? What about gold?
Yeah, that was in the first, I had asked that the last session, but why don't we start from that? David, you doing sleeves?
So yeah, I don't use gold. I have thought about it. It makes sense. It's just hard to know everybody's individual with anatomy. You know, how to know, I mean, green, gold, blue, you know, how fine can you be? So I just tend to do 2 greens to get myself out of the antrum, and then I go blues. If I felt like a blue was too tight, then I would certainly go to a gold.
Roel?
Sometimes I use gold, the third fire, green, green, gold, and then I keep going blue upwards.
Matt?
Same, green's below, gold's, I never use blue at the top.
I don't think you should say you're using blue without commenting how you're handling that at the top. You're suturing at the top.
Yes,
Yeah, Raul's running a suture, so that's a problem. Michelle may know more because he reviewed all these papers, but it's very difficult to sort out how people are handling the staple lines. I use green, purple, or black the whole way up, and I suture invert the top of the staple line. I don't run the entire staple line.
And no buttress anymore?
No, I quit doing that. No, I'm sticking to 0% leaks. Remember, the buttress materials are variable in thickness, and there are a couple series now, 500 plus cases where there's no leak using just buttress without an inverting suture. Michelle's 7-year 0 leak rate, you saw him, he put a suture at the top, on top of the buttress. You can have a negative 0